All right, there we go. All right, so seminars on Thursdays are an opportunity for us to learn something new, which we will definitely be doing today. And part of that, this seminar is a class for students that have a requirement for their degree. We have, I think, 4 students signed up. Maybe it's 3, 2 PhD and 1 master's student. Do I got that right, Todd? I think that's correct. He's a little frozen. Okay. And so just as a reminder for our students, there is a small summary that you'll want to create. We've talked about this previously. I will include an assignments, or maybe Todd did that, an assignments place for you to upload those on Blackboard as we discussed. So just as a reminder for the students attending for the class credit part of our seminars, you'll want to be thinking about just that small write-up that you'll also be submitting. Okay. So then I think we'll just go ahead and get started. We're at 13 people. As people find how to get in here, I'm sure they will join us. But it's my pleasure to welcome Chelsea Priest. She's a licensed dietitian nutritionist, and she's a clinical research associate with us in the Center for Nutrition Research. I think all of you have had an opportunity to read her abstract. We're all going to learn quite a bit. What's exciting about this is the translational piece. Oftentimes we think about all the wonderful research we do, but then where does it go? How is it used? And so she'll be able to help us understand how a practicing clinician will utilize data that is produced by us or from other researchers in the field. So as a licensed dietitian nutritionist, she's done a tremendous amount of schooling, and part of that is that she has a master's of science in human nutrition from the University of Western States. And her focus area has been in applying contemporary nutritional research to the treatment of autoimmune and gastrointestinal disorders. So with that, let me welcome Chelsea, and I'll turn it over to you. Thank you.
Great. Thank you, Britt, and hello, everyone. Hopefully you can hear me okay on this. I am going to share my screen. And just let me know when you can see it up there. Are we good?
Yeah, it looks great. Yep.
Okay, perfect. Awesome. All right, so I'm going to go over the outline with you guys first. I'll introduce myself a little bit more, and then we'll get into it. I wanted to preface by just saying that none of this is intended to be medical advice. It is just to supplement your knowledge so we can build a healthy foundation for contemporary medicine to work. All right, so today I'm going to be talking about nutrition and for immune resilience. The first thing that we will cover is I'm just going to do a little immunology 101 with you guys, just as a refresher. I'm going to go over the immune system just to lay the foundation of what I'll be covering. And then I'm going to talk about the 3 regulators in the immune response, so nutrition, inflammation, and the microbiome, and also the role that westernized diets have in our immune and metabolic health. And then I'll cover some nutritional strategies targeted for building immune resilience. And then finally, I'll wrap it up with a couple case studies and hopefully some time for some questions and answers. Okay, so like Britt said, I am a nutritionist. I am licensed here in the state of Illinois to practice, and I didn't, it wasn't a linear path for me to get here. I had my undergrad in psychology, and then right after I graduated with that, I got a job in human resources where I worked for 14 years. And it was my time there working in a corporate job that I just found myself overworked, working long hours. I didn't have a lot of personal time. And I found that I kept getting sick and I kept getting physically injured. And I was out from hip surgery and I was researching nutrition and wound healing, and I would read research papers on my free time for fun. And I just realized I wasn't where I wanted to be. And it just wasn't what I had wanted to do. And so nutrition really is a passion for me. And I went back to grad school while working. Um, I completed my clinical hours while working in HR still too. And it was from there that I started to work with people with autoimmune diseases. Although I saw a lot of patients with traumatic brain injuries, some fertility patients, and then other chronic health conditions like PCOS and diabetes and metabolic diseases. So I do specialize in autoimmune diseases and GI disorders, but I see, everybody kind of across the board as they come in. That top left picture is just me right out of undergrad. And then the other two are me with my dog in Denver and me with my son here in Chicago. All right. So in this topic, I'm going to cover immune resilience. So I wanted to first define what that is. So like it says there on the screen, it's the ability of the immune system to recover from unfavorable conditions. So this doesn't mean that we'll never get sick, just that we have the resiliency to bounce back from being sick. We want our immune systems to detect and respond to pathogens and foreign invaders. If we never got sick, this just means that our immune systems are suppressed and not responding appropriately. Okay, so some immunology 101. This is just as a little refresher to form the basis of some things that I'll be talking about. So when I am talking about the immune system, I'm talking about the innate and the adaptive immune system. The innate immune system is faster, so it usually responds in a matter of hours. We are born with it, and we have it for life. So that means that it's inherited from our parents. And then it's non-specific, which just means that it will attack any foreign invaders that are presented to it. The adaptive immune response is developed or acquired, as it's sometimes called, throughout our lifetime. And it's a more delayed response. It's usually about 1 to 2 weeks that it activates. And then adaptive immunity is specific, meaning that it can remember specific pathogens, which they've encountered before. A little bit more about innate immunity. So it includes physical barriers such as skin, mucous membranes, and also things like stomach acid, pH levels, and things like that. And then on a cellular level, I'm not going to go through every cell there on the screen. Just some ones of note are neutrophils, which are a white blood cell. They're the most abundant one that we have, and they kill anything that they ingest. This is also called phagocytosis. And in the tissues, they're called macrophages. In the blood, they're called monocytes. And these are also phagocytic. And these are important because they release inflammatory cytokines that help initiate the next phase, which is the adaptive immune response. They do this by presenting an antigen to a T cell, which is a type of adaptive immune response cell. Dendritic cells can also present to T cells, so those are just some ones of note. All right, the adaptive immunity includes T cells and B cells. T cells are matured in our thymus, and B cells are matured in our bone marrow. B cells are important. They produce antibodies. Some ones of note are IgG, which are made towards bacteria and viruses, and IgE are made towards worms and allergies. So on the screen is just a little chart of some of the different T cells and what they do. It's also important to note that B cells and T cells will feed back to white blood cells. So, these are separated out just for visual effect and to kind of learn what they each do, but they are constantly talking to one another and feeding back into each other. So I wanted to just give like a little real world example of what this looks like. So if somebody has a peanut allergy and they ingest peanuts, then a dendritic cell, which is a white blood cell, might come along and present that antigen to a T cell. And the T cell would then release inflammatory cytokines, producing a Th2 response. From this, it feeds into B cells, and that releases antibodies. And the antibodies then feed back to white blood cells. And in this case, it would be mast cells. And that's where we see either the reaction of hives or anaphylaxis. And the reaction just depends on the amount of degranulation that happens within the mast cells. Okay. So I'm going to be talking about the immune-metabolic connection, mostly how our metabolic health influences our immune system. So there's three regulators that I'm going to be focusing on: nutrition, inflammation, and the microbiome. All three of these overlap. So again, these are separated out just for visual effect, but keep in mind that they are dynamic systems that talk to one another, and sometimes they're completely overlapped. You almost don't know where one ends and the other begins. Okay. So when looking at nutrition, that first regulator, we have to put it into context by first looking at the obesity epidemic that's happening in westernized nations. So according to the CDC, 42% of adults are obese in the US, and that's up from 31% in 1999. And worldwide, that number for obesity is at 13%. And while it looks like this is a much smaller number, that's true, it has tripled since 1975. And that tracks really well with the westernized diet being exported to other parts of the world. So, what has led to the obesity epidemic? One source is the westernized diet, also called the standard American diet or SAD. This diet is characterized by being high in fat, high in sugar, refined grains, high in sodium, and low in fruits and vegetables. So, these are calorie dense but nutrient deficient foods that produce a high glycemic index and insulin response. So some examples would be chips, French fries, cakes, cookies, and then high fructose corn syrup items like sodas, juices, breads, even salad dressings. Okay, so what happens when we eat a westernized diet? It leads to all these things that we see on the screen here: obesity, fatty acid accumulation, inflammation, dysbiosis, increased inflammatory cytokines like interleukin 1, 6, and TNF alpha. And then the endpoint would be metabolic disease, insulin resistance. And of course, it's not limited to just those, but just for the sake of this presentation, those are two of the endpoints. So inflammation is really the key link between metabolic and immune systems. Obesity will often lead to chronic inflammation, which then changes adipokines, which are just hormones in our fat cells. And then that affects the immune cells. So, for example, in obesity, macrophages will chronically produce these inflammatory cytokines, and counter regulatory measures fail in calming that down. So, you have this chronic overproduction of inflammatory cytokines. There's several immune cells that are affected by adipose tissue volume because they have immune cell signaling capabilities. So that's a little bit of what we shouldn't eat. I just wanted to point out real quick some key nutrients in having a good immune system. And that would be B vitamins like B1, B2, and B5. These help produce antibodies from B cells. Folic acid, B6, and B12 contribute to the production of T cells. Vitamin C supports T cell function and phagocytic cell function. And then fat-soluble vitamins have a whole range of things that they do, but some of the things are increasing antioxidant capacity, improving B and T cell function, and regulating inflammatory mechanisms. I wanted to point out zinc is especially crucial for immune health. 300 enzymes depend on zinc in order to function. So not enough zinc leads to zinc deficiency, leads to inflammatory cytokines being released, which then leads to infections, oxidative stress, and increased cell-mediated immune disorders, which are just a type of autoimmune disease. And then the trace minerals, copper and iron, help improve function in T cells, antibodies, and phagocytic cells. Okay, so the second regulator is inflammation. This is just a little diagram that I thought showed really well of some things that are taking place. So I wanted to just start out by saying that inflammation gets a really bad rap these days, but it is inherently a good thing. It's a normal physiologic response to injury, whether that be physical injury or infections, toxins, foods. So this is a good thing that's happening. We don't want to completely get rid of it. But what I'm referring to is, of course, chronic inflammation. And that is where the source of the trigger is not being removed. And so you have a chronic overproduction of these inflammatory cytokines. So when does that happen? It happens in obesity. So macrophages will enter adipocytes and help activate inflammatory cytokines like interleukin 1, 6, TNF alpha, interleukin 8. And that creates a local immune response. So with this diagram here, excess energy will be taken in to the adipocytes. The inflammatory cytokines are then released from that. And then not in the diagram, but also important are B cells. These will contribute to the inflammatory reactions because they are triggered by the white adipose tissue, and they will release their own inflammatory cytokines like Th17. Adipokines, which are just those adipose hormones, these can increase or decrease inflammation. So adiponectin helps facilitate glucose uptake, and it is considered anti-inflammatory. This hormone goes down in obesity. Resistin is an inflammatory marker that comes from insulin resistance, and it increases in obesity. And then leptin increases inflammation and is more abundant in obesity. So the immune system responds to poor diet by activating inflammation. These pro-inflammatory cytokines block insulin signaling, contributing to insulin resistance, and that's in the bottom box here. Fatty acids, the free fatty acids are also released, and that combined with the inflammatory cytokines creates lipid peroxidation, and this leads to atherosclerosis and hypertension. Okay, so clinical application. So I wanted to look at how chronic inflammation shows up in a patient. If a patient walks in with any type of chronic health condition, I immediately suspect that there's some level of chronic inflammation going on. So some clinical manifestations of this would be diabetes, obesity, asthma, and autoimmune diseases. And then the patient may complain of joint pain, GI distress, acid reflux, frequent infections, and chronic fatigue. Of course, this isn't a exhaustive list, but it's just to show you a little clinical lens what this can look like in practice. We talked about the cellular level. Well, what does this look like in a patient? And these are just some of the most common ones that I see. All right, the third regulator is the microbiome. So it is quite the hot topic today in research, and for good reason. I wanted to first just define what it is. So the microbiome is an ecosystem that encompasses microbiota, microorganisms, and the host microbe interactions. Some quick facts: 70% of our immune cells are in our gut, so this should signal to us that this is an important part of immune health. Commensal bacteria also occupy space and depletes nutrients, which limit the occupation and growth of pathogenic bacteria. So I like to think of this like a parking lot, and the more spaces that are taken up by commensal bacteria, the less space that there is for pathogenic bacteria to come in and take hold. And so several things can lead to this. It can be diet changes, inflammation, antibiotics. All of those things can deplete the nutrients, and so there's more room for pathogenic bacteria to come in. All right, and this is kind of a busy chart here, but I'll just walk through a couple pieces of it. An important part of gut health is and the microbiome is the mucosal barrier, which just acts as a physical barrier between us and our environment. So what happens when too much pathogenic bacteria comes in? The mucosal integrity is disruptive, and this is sometimes called intestinal permeability or leaky gut. Um, and not only is there more pathogenic bacteria, but there will be more lipopolysaccharides or LPS. And these are just gram-negative bacteria that binds to monocytes and B cells, and they can trigger them to release inflammatory cytokines. So increasing amounts of LPS and pathogens increases intestinal permeability, and this can lead to allowing large molecules to pass through our intestine. Once these pass through, they are recognized by our immune system as foreign, which creates a heightened immune response and higher inflammation. In patients that I see, this is where I see disease flare ups like swollen joints in people with rheumatoid arthritis. So it's no wonder that leaky gut and the disruption of immune cell homeostasis is associated with the development of metabolic diseases, ectopic eczema, autoimmunity, and allergies. I just wanted to point out that short chain fatty acids contribute to the integrity of the mucosal lining. So these are mainly derived from undigested carbohydrates that ferment in our colon, although they can also be derived from proteins, just at a much lower level than carbohydrates. Butyrate is the main fuel source for epithelial cells in the colon, and it helps mucus production. It increases tight junction proteins, which are just exactly what they sound like. They're proteins that help keep the epithelial cells tight together so molecules can't pass through. Butyrate also helps downregulate the cytokines that are produced from lipopolysaccharides. And so when you're looking at how can I get more short chain fatty acids? If you eat a whole foods plant-based diet, it'll provide enough short chain fatty acids to have a healthy gut health. Okay, so what does dysbiosis look like in a patient? It's probably unsurprising that it's found in inflammatory bowel diseases like ulcerative colitis and Crohn's disease. Both have elevated amounts of toxic strains of E. coli and altered bacteria. Dysbiosis is also found in obesity and metabolic diseases like type 2 diabetes because these have higher amounts of lipopolysaccharides. People with autoimmune diseases like RA have altered microflora and a higher incidence of SIBO. And SIBO is just small intestinal bacterial overgrowth, which is an overgrowth of that pathogenic bacteria in our small intestine. So practitioners can order stool testing to get a profile of the bacteria, but this is often costly and insurance doesn't usually cover it. And so it's pretty prohibitive that it can be used. So some common symptoms for dysbiosis would be GI distress like gas and bloating to disease flares like swollen joints. Okay, So then using what we know about the regulators to improve our immune health, I'm going to now build upon that. So to build immune resilience through nutrition, we will target inflammation, the microbiome, and all of this doing nutrition. So as we talked about earlier, we'll be focusing on calming down inflammation, which helps break that feedback loop to tell the immune system it doesn't need to keep activated. So to decrease inflammation, we first need to identify and remove the trigger. If we keep eating these high fat, high sugar items, but we are eating good nutrients with it, we're just sort of putting a Band-Aid on the problem. And we want to eat a variety of plant-based foods to increase our antioxidant system. And all of this will allow those tight junction proteins to heal and normal digestion and absorption of nutrients to happen. And then for the microbiome, we want to help the immune system by limiting the occupation of pathogenic bacteria. So targeting inflammation for with nutrition, I just wanted to point out separately that about omega-3s. I believe the omega-6 to omega-3 ratio is probably at the foundation of chronic inflammation. Um, omega-6 foods get converted into arachidonic acid, which then turn into pro-inflammatory eicosanoids. Um, with the exception of DGLA that you can see up there, that can be converted into, can be anti-inflammatory if there's enough omega-3s present. So reducing the amount of omega-6s is important, but also increasing amounts of omega-3s is just as important. Omega-3s help provide a cell structure, and they modulate cell signaling capabilities in the inflammatory pathway. So some foods that are high in omega-3s, these would be fish items, usually fatty fishes like salmon, sardines, herring, anchovies, trout, sea bass. And then they could come from plant-based sources like flax seeds, chia seeds, and walnuts. These just have to go through a couple conversions in order to get to be omega-3s. And so you need to consume a larger amount of them. Okay, a little eat this, not that diagram. So we want to focus on vegetables, ones with high polyphenol content, like kale, broccoli, spinach, carrots, onions. So polyphenols will help decrease inflammatory markers. Dark fruits are also high in polyphenols. Fruits like blueberries, grapes, and cranberries have resveratrol, which is just a polyphenol that helps regulate inflammatory pathways. Omega-3s, like we just talked about, and then monounsaturated fatty acids help prevent cell stress that are caused by saturated fatty acids. Some examples would be olive oil, olives, nuts, and avocados. And then anti-inflammatory spices like turmeric, ginger, rosemary, and oregano. And then I like to add a high dose supplement of turmeric for patients with inflammation, just as long as it's in fat soluble content with berberine or black pepper so that it can be activated. And then whole grains are rich in B vitamins and fiber. Some examples of this would be steel cut or whole rolled oats and sprouted grain breads. And then, of course, we want to eat less of foods high in trans fats and omega-6s. So some examples would be processed meats, partially hydrogenated oils, corn, peanut, soy oils, which are often used to fry food at fast food places. And then we want to lower refined carbs, which have a high glycemic load. These include white breads, bagels, crackers, cookies, white rice, and then, of course, sodas and juices, which also have a high sugar content. So to support the microbiome, we want to focus on providing a diet that is rich in prebiotics and probiotics. Prebiotics will help feed the beneficial bacteria. So eating a variety of plant-based foods is the best way to fuel those beneficial bacteria. Some ones that are great are garlic, oats, beans, bananas, and watermelon are some rich sources of prebiotics. And then probiotics are live microorganisms that help digest food and prevent pathogenic bacteria from taking hold. Sauerkraut, kefir, yogurt, kombucha, sourdough bread, these are all great sources. And then polyphenols, like we just talked about, can help attenuate a high-fat diet. These have antimicrobial activity as well. So if we do have that pathogenic bacteria taking hold, these will help with that. Eating a high fiber diet helps produce those short chain fatty acids, which is essential for our mucosal lining. It improves circulation, mineral absorption. Some good sources would be beans, berries, avocados, and whole grains. And then lastly, zinc, carnosine, and L-glutamine are just two of my favorite supplements that I use for repairing intestinal permeability. I usually recommend these at a high dosage in supplement form. Okay. So next, I'm going to get to some case studies. Before I get to those, I just wanted to address some problems with translating research into practice. So human nutrition research is usually small sample sizes, and this is especially true for rare disorders. So like when I'm working with people with certain autoimmune diseases, it can be an even smaller pool of people that they're drawing conclusions from. And so I provide personalized nutrition recommendations, and these require several solutions that randomized controlled trials just cannot capture. It is in randomized controlled trials nature to limit variables for good reason. But when I'm working with somebody, they often have several chronic health conditions, are on several medications, and require several different types of treatments. And so I've actually seen some pretty promising advances in AI and machine learning to try to capture those variables and what treatment would be best. But we do have a ways to go before we can get there. Okay, so for the case studies, these are not their real names. The first one I'm going to talk about is Eli. Eli was a 42-year-old male who lived in Alaska. He came to me from his chiropractor. He had had shoulder surgery about 6 months before seeing me and had not done any of the post-op instructions. When we went through his health history, I asked about his diet through a food recall, and he noted that he drank 4 beers a day and chews tobacco daily. And then his diet consisted of mainly red meat, chicken, eggs, and then a lot of refined carbs like bread, chips, muffins, and white rice. So before prescribing any sort of treatment plan for them, I go through a thorough health history. It takes about an hour and a half with them, not just their family history, but also other sources that can be contributing to their health conditions like stress, sleep, family relations, things like that. So after gathering all that information and any lab work that they have that's been done recently, I go on to the diagnosis of the problem. And for him, he had chronic inflammation due to his injury and also environmental toxins that were contributing to oxidative stress. So he was experiencing this chronic production of inflammatory cytokines, which cause swelling, redness, and pain. And just the injury in itself requires antioxidants in order to neutralize those free radicals. But then you add tobacco and alcohol on top of that, and you're just depleting your antioxidant supply, creating oxidative stress. So for his treatment, We increased antioxidants to help decrease his reactive oxygen species, and we did this by increasing polyphenol content. So we added in blueberries, leafy greens, and sweet potatoes. And I don't want to say that he was resistant to change, but he was hesitant to change. And so for him, we just went really slow and added one thing at a time until he felt comfortable making his meals and adding these new foods in. And then he had no problem adding in fish. He ate that twice a week. And we added in a turmeric supplement to help reduce inflammation and restore his immune system. And then we swapped out simple carbs to complex carbs. So instead of white rice, he would have sweet potatoes. And then for him, we worked together for 6 months. He ended up losing 25 pounds. He was overweight when he came in to see me. That was just sort of a byproduct of us working together. But he did have tremendous improvements in his pain and inflammation, and all of his inflammatory markers reflected that. For Rosie, she was a 56-year-old woman who was diagnosed with celiac disease. She came to me with symptoms of joint pain, stiffness, primarily in her hips and her toes. She also had fatigue and brain fog. She would take a nap a day. And then she also had GI distress, mainly bloating and abdominal pain after she ate, and then up to 5 loose stools a day. So her typical day's diet looked like maybe some oatmeal and milk in the morning, tacos for lunch, a gluten-free energy bar, and then chicken, veggies, and rice with soy sauce for dinner. So, objectively, it seems like she's not eating too bad. She wanted to see if her diet was playing any sort of role in the symptoms that she was having. So for diagnosing her, she has celiac disease, which means that her body has produced antibodies against gluten-containing substances. Gluten contains gliadins, which destroy the microvilli in the small intestine. And when there's damage that happens to the microvilli, there's an inability to digest and absorb nutrients. She was also probably experiencing secondary lactose intolerance because when those microvilli are destroyed, so are the brush border enzymes, and one of those is lactase that is produced by that. And so it's pretty common for celiac disease patients to have secondary lactose intolerance as well. And so for her treatment, we started out with education. So she was choosing gluten-free products, but there's a lot of hidden sources of gluten in things like sauces, dressings, even shampoos. So I had her remove oats, since these can be cross-contaminated from or with gluten. And then I had her do an elimination diet for 8 weeks where we remove all potential allergens, and then we reintroduce them one at a time to see what she's reacting to. And while we're doing an elimination diet, we also focus on healing her gut. So I added in during the elimination portion of it a supplement of Saccharomyces cerevisiae varbillardi. This is just a probiotic that helps heal the mucosal lining and also brings normalization to the microvilli and helps upregulate those brush border enzymes. A supplement of L-glutamine. These help heal the enterocytes and reinstate the mucosal integrity. And then with meals, she would have a digestive enzyme. These just help break down and absorb nutrients while she's working on repairing her gut. And she added in a high dose multivitamin because she was probably lacking in essential vitamins and minerals at that point. And then lastly, a turmeric supplement to reduce inflammation. So at 1 month into treatment, when she was still doing her elimination diet, she reported having more energy. She no longer needed a nap during the day. She didn't have any more joint pain during the day, although she did still have some at night. She didn't have any bloating or abdominal pain. Her bowels were becoming more solid, and these reduced to 2 to 3 times a day. At the 2-month mark, when we started doing reintroductions, we identified a lot of her triggers, which were dairy, hidden gluten like oats and corn. And then after seeing me, she continued on a gluten-free diet, low lactose diet, although she did still eat dairy products with probiotics in them, like yogurts and cheeses. And so the goal is always to put patients on supplements just for a short-term basis and then get them off all of them. And then also for us not to have to see each other anymore, right? So we stopped working together after 3 months, although I do still see her about every 6 months to a year when she needs a little tune-up, just when she gets off track and kind of wants to identify what to do next. And I think that is it. So here's some of my references, and it looks like we have some time for questions and answers. And I'll stop sharing. Here we go.
Okay, well, thank you, Chelsea. It was a wonderful presentation. We have about 10 minutes for some Q&A.
We have a couple hands up.
All right. I'm not seeing where the hands are. So Cindy, if you can see Catherine
and Vara.
Catherine and Vara. Let's start with Catherine, and Vara, you'll go next. Go ahead, Catherine, unmute yourself.
Okay, hopefully you can hear me. Hi, Kelsey.
Hello.
So my question from your case studies is, like when are you measuring inflammatory markers like across the treatment of those patients, and which ones are you testing? And then I have so many questions, so I'm going to try and limit it to 2 to start, just to be fair. And then the other question I have is if there's a concern for turmeric supplements for increasing liver enzymes, since I've seen that off and on, just sort of as on a case study basis, I guess you'd say. Mm-hmm. And then, how you go about choosing supplements to work with individual patients, since a lot of times they don't have the same level of robust studies that some of our other MNT might have.
Yep. Yeah, those are all really great questions. And just because it's on the front of my mind, yes, you're absolutely right about supplements. It was probably the most exhaustive part is I had contacted each supplier that I work with, and I have a sheet that I have questions for. Where did they get these ingredients? How are they sourced? So that I feel comfortable. And then I also make sure that they're third-party tested as well on top of that, because I'm sure, as you know, these supplements can be adulterated with all sorts of things. So the ones that I use are pretty reliable. It's usually a different brand for whatever the supplement is. If they're good at probiotics, or they might not be good at turmeric, So that was that question. And for testing lab work, so I've always done my work in coordination with a doctor. And so the doctor orders labs, and we do this at the beginning and then at 6 weeks. I've also done it where it's been the beginning, 6 weeks, and then 12 weeks. That just depends on the patient and, what they're able to afford. And we generally run just a normal CBC just to check everything. For inflammatory markers, CRP, homocysteine, those are the ones that we usually look at. Did I answer all the questions?
Yes, thank you so much.
Okay, yeah.
Okay, Vara.
Yeah, hi, Chelsea. This is a very good informative presentation. Thank you.
Yeah.
And I am Vara. I am a PhD scholar. I have a question in the T cells group. You mentioned there is a T helper 1 and T helper 2 and T regulatory cells. Is it a T reg is a T regulatory cells or a separate group of T cells?
Mm-hmm. Was there a question?
The T reg is a
Yes.
separate group of cells, or or else it is a T regulatory cells.
Yeah. Yes, they're separated.
From the T group of cells?
Yes. So these are Treg cells,
Mm-hmm.
right?
Okay. Yeah.
Yeah. So
Thank you.
they don't produce like an immune response.
Uh-huh. Okay. Yeah. They never involved in the cytokine production.
Well, yeah, that I don't know. I don't know if they release inflammatory cytokines. I just know, like, in the research, like Treg cells are kind of what balance that Th1 and Th2 response.
Okay.
Yeah.
Yeah. Thank you.
Isad?
Todd?
Hi, Chelsea. Excellent presentation. I really liked it. And my question is kind of similar to what Catherine was asking. Your coordination with the personal doctor of your clients. How do you start? This coordination. Does the doctor refer them to you, or they find you first and then you order tests? How does it
Yeah.
work? Thank you.
Yeah, both. So I've worked with a couple different doctors. From one of them, they purely brought in all of the clients, and then I was kind of an add-on for them, that I would see them too. These were like the fertility patients that I worked with. But then when I worked for with a chiropractor and a doctor as well, that came in from all three sources, and then we just it was like a coordinated thing. Like, I'm a contractor with them, but we would do coordinated care. Does that make sense?
Yes, thank you. Do you have also patients who directly come to you and then, without the referral from the doctor, and then what do you do with them? Do you order certain tests, blood
Mhm.
tests, other tests?
Yeah. So for the people who come to me, it really just depends on if they're able to afford that added on care. Not all of them get blood tested and have that level of care. Some people just want nutritional counseling. But for people with autoimmune diseases and things like that, like they usually are able to um, take on a little bit more financial responsibility. So I will say all of this is cash base. This isn't run through insurance. This is a private practice. So it really just depends on what they're able to afford financially.
So insurance doesn't cover any of your services.
We don't bill insurance.
Okay.
Not that it doesn't cover it. It's
Oh, okay.
just yeah.
Okay. Thank you so much.
Yep.
All right, I'm on.
Hi, Chelsea. Great presentation, and it was great to hear from a perspective of a dietitian. So my question is pretty simple. Like, how often do you see recommended patients by the doctor? Like, is the number more coming from doctors' referral versus people are just coming by themselves
Ye-
to you for suggestions or advice?
I would say the majority of them come from the doctor, and that's mostly because of my just limitation in marketing and having the time to really get out there and market and do all of that. And so it's been easier for me just to set up a referral network, that then I can see them that way. I have fellow nutritionists that do it the opposite way. They all come through the nutritionist, and then they coordinate care with a fellow doctor. But for me, it's really just because it's time prohibitive. I work here as well, so it's just not feasible for me.
So do you think there is a gap, like patients are not aware of these services, that this needs to be promoted more by the medical practitioners so that they can avail this facility, like curing themselves by eating right kind of food versus eating medicines?
Yeah. Well, I will say that it's mostly a changing landscape in care. So I have all of my training is in personalized nutrition. So I don't have a formal like dietitian route that I took. I have never worked in a hospital or anything like that. But it's kind of part of this new movement, right, of precision nutrition. And part of that is this multi-level care model, right, where it doesn't just take a nutritionist to solve somebody's chronic health conditions. I mean, I've even worked with therapists who, some people have trauma issues around food and they need those solved. And so, yes, I do think there's a huge gap, but I do think that it's moving in the right direction. There's just, for right now, like, on the topic of like insurance, there's not a great way of getting these things billed, depending on what it is. It's just much limited care that we can give. For me, I don't bill insurance just because it is a total headache. And so, for right now, that is definitely a gap between who needs care and who's getting it.
Okay, thank you, Chelsea.
Mm-hmm.
Indica?
Indica,
It's my chance, right?
it
boss.
is. You're on.
Okay, Chelsea, my question is relevant to the compliance. So one of the core criticism that one of the biggest challenge with the nutritional, I would say nutritional personalized nutrition, that therapy kind of area versus the medicine is the compliance.
Yep.
When the doctor asks you to take a pill, they're probably going to take it. But when you ask them to follow a certain diet and change the diet and exercise, and when you give the whole package, people are less reluctant to follow that regime as opposed to one pill. So with your experiences, what kind of strategies that you use to make sure, I mean, the compliance is very low, we know that. So what kind of strategies that you use to increase the compliance?
Yeah, well, I think this is one thing that like there's going to be so many different things across the board. So I'll just give you an example that like people with autoimmune diseases, in my experience, have been much more willing to comply because they are experiencing symptoms that are in their face daily. They're in pain, right? It's limiting their quality of life. And so there's much less that I need to do to handhold with them to get them to kind of jump that fence. So it really depends on the patient population. Now, I'm pretty sure you're referring to people with like pre-diabetes and these other chronic health conditions. I don't have like a great answer other than, motivational interviewing has helped. But this is one thing where I think like a coordination with a therapist or just more training in cognitive therapy in general can really help in this area. But yeah, that's just not my main population that I work with. One of the reasons that I loved working with people with GI disorders and autoimmunity is I saw such an amazing transformation in people because of their willingness. They stick to it, they do it, they follow through, and they have tremendous differences in their health. And it's completely rewarding for me. But I know that there is a huge need in all these other chronic health conditions, since that's the big driver of a lot of our problems here, right? Yeah.
Any other questions?
Any other questions? Yeah. There we go.
I did have one quick question. I know you were talking about zinc.
Mhm.
What's the recommended dose to take daily? Because I
Yeah.
have conflicting things on that.
So I'm never going to give you a recommended dosage because all of this is based on personalized lab work, health history, things like that.
Okay.
Yeah.
Thank you.
Sorry.
Great presentation.
I'm like,
No,
I
that's
know it's
okay.
really annoying to hear.
So tell her if there's too much. She shouldn't be taking too much. Is what it is, right?
Well, because I usually take 50 milligrams, and I try to remember to take it daily. But then when you look online, it says 8 milligrams for women and 11 for men, and that taking too much could hurt you.
So Cindy, make an appointment
Yep.
so that you can have your work done.
I was just thinking about that. 'Cause I am one with autoimmune disease, so Chelsea, I'm going to be knocking on your door.
We'll take one more question from Morgan, and then we're going to have to end so that we can be relatively on time. So go ahead, Morgan.
Okay, so well, great presentation, Chelsea. Quick question, I guess. So how, as far as like personalizing your plan for your clients, how much consideration do you take in as far as like maybe their economic status, where they live, just kind of maybe their profile as a client?
Yeah.
I kind of thought about this when you talked about one of your clients or patients being from like Alaska. Like how does that factor in when you're prescribing?
Yeah, it's a huge factor. I mean, it'll determine how much I'm recommending, because if it's not just their socioeconomic status, like, you know, how much money that they might have available, it's also what support systems do they have there to making the changes that they need as well. So all of this is like covered in the health history that I go through with them, so I can get a better idea of you know, what's the best care for them and where they're at. So all of that is included and factored into what is the treatment plan.
Thanks.
All right. Well, we are out of time, but please join me in thanking Chelsea. We are very grateful for your presentation today. It was fantastic. I wish we could hear from you more often. So
Thank you.
let's talk about that. Thanks everyone for coming. We appreciate your attendance. Feel free to drop us an email and tell us what you liked about the presentation and other things you'd like to see. And we invite you to come and enjoy our next presentation, which is what, Cindy? You know that?
Next week, it will be Kate Ping. She is presenting. And what
Excellent.
I'll be sending out a reminder today.
Okay. Thank you, everyone. Have a great rest of the week, and we'll see you all again soon. Thanks again, Chelsea.
Bye.
Thank you.